to get us live?
Sure.
Going.
Did you get these two sheets?
Eileen's on my list, but not for a while.
Okay, we're all set.
Oh, thanks, Jan. Okay, all right. So introductions. I'm Elise Schweitzer, Chair of the Mental Health Services Board.
I'm a Shanae, a member of the board and new member of the board.
Randy Brown, I'm my second year as a legislator and I'm replacing Veronica. And she's moved on to another committee. She's not in the committee, Health and Human Services Committee anymore. So opportunity was there and I thought I could learn something. So
Welcome.
Yeah, welcome.
Really glad you're here. Good evening, everybody. I'm Travis Winter. I'm on the board.
I'm Janet Thibodeau. I'm the Quality Assurance and Improvement Coordinator.
Corinne Palazzo, legislative, LGU administrative assistant.
Frank Ruba, Commissioner.
Sheila McHenry, member.
Mary Hutchins, member.
Jan Lynch, member.
Can we just do,
Larry Roberts, member.
and can you hear us all okay, Larry?
Yes.
Thank you.
Okay, and do we have? No, that's us, Gina Tibdo.
Yeah, that's Janet.
Oh, sorry.
We gotta-
That.
I'm finagling to make the IT work.
Okay, great.
Impressive being in two places at once. I like that.
All right, any additions or deletions to the agenda? Okay, privilege of the floor. Questions or comments? Ready? Board correspondence or announcements. I just wanted to make a couple of brief announcements. I've been looking at the bylaws for two reasons. One, because we do need to amend the bylaws, so I'm hoping to do that next meeting so that we can add in the language about the regulations around public meetings and virtual participation. So we're supposed to adopt a clause and add it to the bylaws. So I will probably just draft something and send it out to everybody to review, and then we can discuss it and debate it here and hopefully finalize some language. If we're not ready to vote on it next meeting because people have opinions, then we can talk about it. I had sent out the information about the reg, so people have, yeah. So I mean, obviously, we don't get to create our own rules. We have to follow the rule, but we may be able to develop some flexibilities or just clarify things for people as well. So I wanted to do that next month. The other thing I wanted to put on the agenda for next month, and just to give people a heads up about it, is I just wanted to talk about committee assignments. So nominating committee, as I was going through the bylaws, to think about adding the clause about virtual participation, I was going through the committee responsibilities, and I noticed that nominating committee needs to be reappointed annually. So I want to reappoint nominating committee next month. So people who are interested in nominating committee, could you please email me and tell me whether or not you are willing, if you're already on nominating committee, if you're willing to do it again, or if you would like to join nominating committee, and if you would be interested in the role of chair. So, and I wanted, hopefully, I'll email Stu with that information because he's currently the chair. So I just want to know you're interested in being in the nominating committee, whether or not you'd be willing to serve as chair. And then in our, I guess it would be our March meeting, I'll reappoint the nominating committee and chair. And then the other thing I wanted to talk about next month is also just kind of revitalizing the committee work in relation to the work of this board. So maybe reinstating reports, thinking about composition and representation and the role of chair and all of that. So I just wanted to give people a heads up that I'd hope to have a dialogue about that in March. Anybody else have any announcements?
You do have a quorum now if you'd like to go back to the minutes.
Oh, great. Okay. All right. So if everyone has had a chance to review the minutes from last month.
That's just 1 month.
It was just 1 month. Yeah.
That's one. Yeah, I'll make a motion to approve the minutes for the last meeting.
Second.
Okay, 1 second. And all in favor of approving the minutes as written?
aye,
Great. Done. Okay, so next up, Commissioner's report. Frank.
Great, thanks, Lise. A good topic on the bylaws, since I was gonna mention that as well. So I want to make sure you have the updated bylaws, because we do have an amended version of bylaws that this group worked on last year. It was actually ready to go to the legislature, but we pulled it back because there was conversation, as we understood it from the legislature, that they were considering new rules for advisory boards, including the potential for term limits, which would have changed what's in the proposed community services board bylaws. I checked in today with the chair of the legislature and the clerk, and it doesn't appear that that is moving forward in the near future. And so I think what we're going to do, but now we'll wait until you have a chance to kind of go through that review, is we'll put forward for approval the bylaws as amended. And then if there is a change in policy from the legislature, we'll just amend the bylaws to do that. We were set to do this in November, I think is when it was going to go through the process, but we pulled it back. But it seems like now we might as well just go ahead and do it, because we're out of compliance with several parts of the rules of the legislature for advisory boards in our current bylaws. So we want to get it updated so that stuff is taken care of. So we'll make sure you have the amended. Do you have the?
I have the version from September of 2022, and I don't know if that was the amended version or
It
not.
should be the amended.
Okay.
version. Yeah. I'll look at, I'll send you.
Okay, yeah, just if you could send it.
So as soon as you guys are ready to, we'll just move that forward. The Board of Health is in the same boat. They have amended bylaws that we held back in anticipation. So we'll be able to move those forward for you. And then the other thing that I wanted to talk a little bit about is opioid settlement dollars. So I think you all are probably aware that there's been money coming to the county from the opioid settlement funds. Those are allocated to the legislature for distribution. They have put together a task force that is working on recommendations on how to use those dollars. Randy is actually a member of that. There's several other community members as well that are part of the substance use community in various ways. So their role is to ultimately make a recommendation to the Health and Human Services Committee, which will make a recommendation to the legislature on how to spend those dollars. So that work is underway. There's about $700,000 right now of one-time funds that is in the pool that they're doing. What we now know is that there will be additional funds coming to the local government unit, meaning the DCS and you all as the Community Services Board. So we are still waiting to find out what those amounts will be. There's a bit more structure to those dollars because it's coming through Oasis, and Oasis is used to giving us money and expecting us to put it out and use it in the community. There's kind of two components of that. There's an actual specific amount that we think is about $150,000 that has to be spent in the city of Ithaca. So it's city specific. And then there's a regional pool. The economic development region has gotten about $4 million that will be allocated out to the counties that are in that region on a percentage method. We're still waiting for notification on what the percentage will be and what the amount will be. So those dollars will go through our usual process, which is we'll review, make recommendations to you all, and then you all will ultimately tell us how you want those dollars spent. So there's kind of two sets of money, two different processes. Just to make it a little bit more complicated, Oasis and the state is also getting money. So they're going to be spending on things, and the ability to kind of coordinate all of that is probably out of grasp. I think locally, we'll be able to communicate with the task force about what it is you all propose to do, because you're going to be on a quicker timeline. We've been told by the state that we have 4 weeks to kind of tell them what buckets we want to spend money in. So there's 9 or 10 buckets that were established through the state review process of the opioid settlement funds. They're pretty wide reaching. So pretty much anything I think this group is going to want to do will fall into those buckets. But we have to give them some indication in about 4 weeks' time about what buckets they're going to go into. And then we would subsequently have to give them more detail about how those dollars are going to be spent. And then we would contract as we do and so forth.
Frank, I think Larry has a question.
Oh, sure. Go ahead, Larry.
I'm sorry, I just wanted to, the money that's earmarked for the city of Ithaca to be used in the city of Ithaca, I think it would represent an opportunity to talk to the city of Ithaca about what they think would be useful to do. Particularly, I'm thinking not just about the city government, but also family and children's and the outreach workers. I mean, there might be a way to use some of the opioid money to build up what they're able to do in the city.
Yeah, I think it's really going to be kind of up to the board to give us some guidance on the approach that you want to take in relation to getting feedback. We'll take a first stab at it and give some recommendations. So at least you have a place to start from in alignment with the local services plan, which is really how we're supposed to do this. And then you all can kind of give us the direction on how you want to move forward and who to include. Yes, so whatever direction you guys give us, we'll certainly take on that.
What is the time frame for the legislature to make a decision?
There isn't really a time frame. We want to move as quickly as reasonable, but for the task force, there's been a lot of information gathering at the beginning here. There's been presentations from different organizations that serve folks with substance use disorders. Tomorrow at our meeting, half of the agenda is saved for the beginning of the structure on how they want to receive proposals. Because ultimately what they'll be looking for is proposals from the community about how to use those funds. But we've got to put a framework to that. And similar to how you all have done with the local services plan and kind of prioritize things, they're going to need to do a little bit of that before they, go through that phase. So we're just trying to begin to put the framework together on how to do that and what rules that group wants to place for that process. So they're different, and I would imagine this one is going to move quicker than that one will.
So is it an actual RFP or RFO, or is it just you're getting opinions?
I don't know that that's been decided yet. I think ultimately they're going to want actual proposals, but I don't know if the RFP process is the appropriate tool or mechanism. I'm not saying it is, and I don't know. So it'll be a matter of, the committee, the task force kind of working through that and getting some guidance from, the legislature and the county administration on what the appropriate mechanisms are to solicit that kind of input. Right now, it's been information gathering and asking, what are people currently doing and what gaps are out there. Next phase, when we get into asking for requests, will be a little bit more formal. I just don't know exactly what that process will be. A similar thing happens here too, right? You'll have to make some decisions about the approach that you want to take. I mean, we already contract with many organizations in the community, and that could be added on to their existing contracts, or you could, direct us to do some sort of RFP process if that's what you chose to do. I think we're hoping is.
I'm sorry.
Oh, I'm sorry.
Because I'm new, I'm not sure what all the acronyms.
Absolutely. I apologize for that. So RFP is request for proposals.
Okay.
So it's a tool that we use in government because we want to get different opportunities for people to ask. Yep.
I think that the task force is eager to do something, but we don't want to rush it.
Yeah.
And we got proposals from CARS, Reach Medical, from Alcohol and Drug Council. They've all made presentations to task force as well as the whole health department. And so now and it's pretty broad, as Frank was saying, from housing to staffing to helping people with the cost of getting treatment, those kinds of things. So it is pretty broad, and then money can go pretty quick.
Yeah. And that's one of the challenges. We don't exactly know how much it's going to be over time, right? Money keeps trickling in. We just had a meeting today with the finance folks and county admin to try to track it all because it's coming they're settling with multiple different companies. And then that money comes in different ways, and it's not exactly clear when it comes to us where it's coming from. So we're trying to put a system together to be able to track it effectively. But it's also hard to make decisions about how you want to spend it if you don't know how much it is and whether it's one time and such. Most of it is one time, at least here in the beginning with the task force monies. They are able to do multi-year. I did find that out. They are able to say, instead of giving somebody $100,000 this year, you couldn't give them 33,000 over 3 years, bless you, for folks. Because when you're talking about staffing, one-time money doesn't really get you there. So perhaps getting 3 years under your belt or something, you could build a program that you could find funding other places, that kind of thing. So all of that'll have to be considered as it goes. But sharing all this, because we just want you guys to be aware, we're on a fairly tight timeline. So likely at your next meeting, we'll be talking about the buckets that we want to put things into. And then from there, we'll, figure out what the actual formal process is. We're hoping to know next week what the allocation is from that regional pool, assuming everything goes as they've told us it will.
Do you know the buckets yet?
Yeah, we can send those out to you. They're
Please.
they're the buckets that are in the state had an opioid task force that developed a kind of a proposal. And so it's the buckets that came out of that. So you may have seen when they did the press releases around that. So if you did, it's those buckets. If you didn't, we'll get them out to you so you can see what they are. It's what you would think. Treatment, harm reduction is in there, which is interesting. The state has said they're not going to spend any money on harm reduction. Or at least specific parts of it, like overdose prevention facilities, that kind of thing. So it is an interesting kind of, dynamic with the dollars and what they've heard. But we're going to do our best to make it as clear as we can for you, but just know that we're working in an imperfect system with all of this. And we just want to make sure that you have everything you need to make the best decisions you can.
Larry, did you have another question?
No.
Okay.
And that's all I had, at least.
Okay, all right. Any other questions for Frank? I hope to see, and you'll send out the information about the big buckets and maybe it's in there, but I would hope to see, I think there's a lot of focus on people who are already, dealing with substance use disorders related to opioids. I hope that there's some recommendations around outreach to casual drug users because of the, I don't know how well understood it is that opioids are a very deadly danger to casual drug users, even sometimes marijuana that's bought from sources that aren't clear. So I especially worry about that in this town with 30,000-ish college students and our high school student population as well. I think that we are a breath away from a tragedy. At any moment in time, someone could get a bag of cocaine. And I just don't think there is enough outreach and education to young people in this county around those topics. So I'm hoping to see something.
The task force has definitely voiced interest in that as well. Yeah.
Anything else? Right. Okay. All right. Annual incident review, Gina.
So if I do present now, will that work?
It should.
All right. Larry, what do you see?
I see it. I see the first page.
Is it in present mode?
Yes.
So you guys maybe won't see the present mode, I guess. Unless anyone has a way to fix that.
Can you click on the bottom right, the present down there?
These?
No, over one more.
This?
Yep, click on that.
Oh, good. Larry, do you still see it?
Yep.
Okay, excellent. Thanks, Frank. So my name is Jenna Thibodeau. I am a co-chair on the incident review our corrective actions and what the committee has accomplished over the last year. Oh,
Does not.
Larry, are you still there?
Yes,
Okay, great.
So stop sharing
Stop sharing.
over here.
Okay. Sorry, we're having technical difficulties.
Give me 1 second. I thought I had a whole new plan to make this not be a problem. Okey doke.
I could do an interpretive dance.
Please do. It's gonna take me a minute.
Oh.
You doing?
We'll call it the white flower dance, Larry.
Yeah,
Share my screen.
Some people have white, notice he has white gladium.
Oh, you're gonna put it up there.
Yeah.
Oh, okay.
Just hope it doesn't crash, man. Okay, just tell me when to move. Like,
Next slide. So this is the membership. It has largely stayed the same except for, there's been some staff turnover for a forensic social worker
You
and
might want to tell people what it is first.
what the incident review committee is.
Yeah.
Oh. So OMH is our regulatory body and they require us to have an incident review committee. So there are criteria which make an incident reportable to OMH and or the Justice Center. And so then every month we meet as a committee, which has a required representation. And we discuss the case and think about the root causes behind what created the incident and what processes we can change. So we don't look at the clinician the primary clinician and oftentimes the medical provider will be present and they will present the case. So it's not about what they did wrong or blaming them. It's about what can we do better as an organization to prevent these things to mitigate risk in the future.
Within Hawkins County Mental Health?
Yes.
Okay.
Yeah, so just to clarify what your role in this is too. So the committee meets and they're looking for trends and things. As the advisory board to the clinic, you have a responsibility of hearing about trends and other things that the committee has uncovered, just so you can be aware and make sure that we're doing things to address those. It's not the role of this group to be digging into individual cases or the specifics of them so much. It's more looking at trends and other issues that have been addressed and making sure that the department is taking steps to address those going forward.
So Susan Spicer is our clinic director and she is the other co-chair. Mary is on the committee with me. So we've also added all of the senior social workers to the committee because there are policy changes and process changes that it's good for them to be aware of. And then I won't go through everyone else. Okay. So this year we reviewed 27 reportable incidents.
And if you just hit that little one to the left there,
This?
that'll minimize it down.
Between January 1st of 2022 through December 31st of 2022. I'm ready for the next slide.
Oh, God, I'm in charge of that.
So of those 27 cases, there were 10 deaths. 8 were attributed to natural causes, which are unrelated to mental health diagnoses. 2 were fatal overdoses. One of which specifically was partially prescribed medication, so it wasn't necessarily an opioid overdose. There were 13 suicide attempts and 3 other incidents, all of which were a violent crime. In comparison to 2021, there were 23 reportable incidents. So there was a decline in the total number of deaths. There was an increase in the number of suicide attempts, and there was an increase in the number of violent crimes, just comparing from one year. And I think, yeah,
I'm sorry, can you move your name over so it uncovers that?
I got that.
That's all right.
You'll probably get to this, but
Yeah.
can you speculate why there was an increase in the number of suicide attempts? And increase in violent crimes? I mean, do you talk about that as a committee?
I mean, personally, I think part of it has to do with the COVID-19 pandemic and how people are responding to that and the way that their social structures are being stressed through time in different ways. Our clinic director also noted that if we have one client who has multiple suicide attempts, that will show up 6 times. Or it could show up 6 times. And actually we did have one client particularly who had multiple attempts this year. So that's part of it.
And with the attempts, are they if that the patient is reporting that to the therapist, is it are people being prompted, like are we doing like PHQ-9s or something to ask about it? How is that data collected?
Yeah, so oftentimes they're hospitalized, which is how we learn about it, because we share information with CMC and some of the other regional hospitals. And then we have a utilization review process where we look at every case that has a reportable incident, and we look for a variety of assessments, including a violent screener, a CSSRS, a substance use assessment, and a safety plan.
Okay.
And then we give feedback to the clinician about those particular forms and any other documentation which is specific or relevant to the case. That is sort of categorized different than a corrective action because it's specific to that client and that chart versus what's a systemic change we can make. So maybe it is improving our ability to do risk assessments, which actually we did address. But if it's client specific, it doesn't really classify as, we don't like address it as a process, if that makes sense.
Yeah.
Any other questions?
I have a question.
Yeah.
Is there a specific age that you're collecting this data for?
Our clients, I think, are 0 to death. So,
Yeah, okay.
yep, everyone. Oh, it's you. So the categories of corrective actions that we saw in 2022 were addressing co-occurring substance use disorders, coordination of care, staff retention, caseload management and client engagement, and improving building security. So some of the things that we did to address co-occurring substance use disorders, we became an opioid overdose prevention program in July of 2019, which means that OMH provides us with Narcan kits that we can distribute directly to clients. So either clients who have an opioid use diagnosis or people who have someone in their family or who's close to them who have who are opioid users. And then we were successfully recertified in 2021, and I believe it's a 2-year cycle. That we provide a short training to any client who receives a kit. And so the link, I'll share the PowerPoint with you all, but there's the picture of the first part of the video and the link for the video if you all want to watch it. We also prioritized co-occurring disorders as part of our 2022 strategic plan. So we had a series of trainings. Dr. Flavio Pasoy is the OMH medical director of adult community services and managed care. So he came and worked with our organization on 3 different occasions. One, he provided an all staff training on the 15th of November for the co-occurring disorder pathway to care. And he just did an overview of a variety of things. He covered a lot of information within an hour, including medication assisted treatment and motivational interviewing. Then he spoke directly with our leadership staff on integrated care the following day. And he provided clinical supervision to our medical staff and supervisors on November 29th. So we looked at specific cases from the incident review committee and talked about what we could have done. Our medical director, Gerard Lippert, also provided a training to clinicians on medication assisted treatment and opioid use disorders in May. And Alcohol and Drug Council provided a Narcan certification training using substances and harm reduction in November of 22.
Those 3 bullets happened in 2022. They're not 2023.
Did I say 23?
No, it says 23 on the slide.
Yeah.
I'm sorry, you're right.
They're not future. Are you good with this one?
Yeah. So this is data. So this is everyone who was admitted in 2022. So whether or not they got a substance use assessment. Ideally, this happens as part of the intake process. So by their second intake, they have a substance use assessment completed. We don't do them for people who are under 12 years old unless clinically indicated. So a lot of the ones that don't have one are likely children. Unfortunately, our electronic health record doesn't easily allow us to parse that data.
This is clients admitted to the outpatient mental health.
Yes.
Okay, thank you.
Yep. I'm ready. Unless anyone has more questions.
I already forgot.
So we also, as a committee, there were 8 natural deaths. Some of them were tobacco users, and there was a discussion about how that really is a factor that we need to address and take seriously. So we provided an all-staff training on tobacco cessation with our dual diagnosis coordinator, Rich Shaw. And that one was this year in 2023. And then we ordered tobacco cessation materials to have in the building to raise awareness and to remind clinicians to talk about it with their clients. And the link for free materials, which was difficult to find. So it is included in the PowerPoint. Larry, did you have a question?
Yeah, I have a question because you mentioned the number of deaths and that smoking was part of the profile of some of the people who died. I have an additional question, which is, do you have a sense of what the diagnosis was of the people who died? In other words, were they mostly people who have more serious mental health labels, or was that not looked at?
Mary can help me out here, but I think that some of our clients are older, and I think that there's a relationship between people's mental health and their physical health. And a lot of our clients have very significant physical health
Yes.
Diagnoses that really impede their lives and their ability, and that also has a interdynamic relationship with their mental health. So I think that's a good question and also a difficult one to answer broadly.
I just know that in general, the thinking is that people, especially people who are labeled with the more serious mental illnesses, have less positive health outcomes, including that we tend to die younger than the population in general. So I was wondering if we are tracking that, especially for people who spend any time in the inpatient system.
I think initially anyone who is a client here has a mental health diagnosis.
Right.
If we determine that they died of natural causes, the reason for their death on their death certificate was a physical health cause.
Yeah, I know. It would just be interesting to look at, you know, who's dying when, and if there's a correlation between people's experience in the mental health system or their experience with the diagnosis and early death, because there is research that shows that people with the more serious mental illness diagnoses tend to have less positive health outcomes, and B, tend to die earlier.
I would say qualitatively, absolutely, yes. That's entirely true.
Okay.
For many reasons.
Yep.
Ready.
So some of the things, this is a broad strategy to address the ways where both documentation and client engagement maybe could have been tighter. And so we have collaborated with the clinic director and the senior social workers to provide monthly metric packets to clinicians, which have their personalized caseload per clinician with relevant data, which is digestible, so it's not too much and it's not too little, that's actionable for them to follow up with people. So then those caseload lists are reviewed with the clinicians during their supervision monthly. And then clinicians are provided a quarterly no client day so that they have time in their schedules where they can go through and follow up with clients to make phone calls or finish documentation or provide engagement. We also have a weekly risk list, which goes out. It goes out the night before our treatment team high risk meeting. So that's a meeting where the clinicians meet with medical staff and they discuss specific cases and what the follow-up is for high-risk clients specifically. So the night before, they get a list with their caseload, who's high risk on it, so the last date they were seen, the number of days since they were seen, their most recent substance use assessment and their most recent safety plan. So that gives them sort of a red flag if anybody's fallen through the cracks, that they can discuss it with the rest of the treatment team and decide what to do.
How is someone labeled as a high-risk patient?
It's a great question. We have a high risk policy that we actually have a risk rubric. So those assessments that you asked about. So there's different kinds of risks. So if they have a violence risk assessment that they're test positive, or they are positive for homicidal ideation or a CSSRS, so they have suicidal ideation, or they have severe depression. Those are all ways to sort of make it onto the high risk list. And then there's also criteria if they were hospitalized, that automatically will put them on the high risk list. If they overdose, they'll automatically go on the high risk list. And then there's a response rubric. So how are you supposed to change your clinical care as a result of that person being either high or moderate risk? And so it's increased visits or increased services in a variety of different ways, depending on what the reason for them being on the risk list is.
Oh, wait, hold on. I've got like 3 more questions.
Yes.
I'm sorry. Quarterly meeting once every 3 months. They get a chance to.
No client day.
Okay.
So they have a day without appointments.
And what are, if it's not too much to get into, the metrics that the clinicians are provided?
So some of it has to do with those items there about, let me think if I can remember everything. We just redid it. So it's their show rate per client. So they can see if they need to address engagement with a specific client. It's also their productivity. So how many clients they're seeing per week or per month, compared to the amount scheduled. So it's not just their show rate, but also how many clients that they intend to see. And then some of the documentation things for assessments and safety plans.
Okay, thank you.
Yep. So this just sort of highlights the process. So they receive those weekly updates and then they review it in the treatment team meeting collaboratively. So while we do have a policy and a rubric, some of it is also qualitative and person-centered and clinically indicated.
How many clinicians are there?
No, I was trying to count earlier today.
Some. 30?
Yeah, it's probably 30 all in with medical staff too, right?
And is that 30 FTE or is it a smaller number of FTEs?
I think everyone's full time. Yeah. So it's both fully on FTE.
A reoccurring pattern that we identified on the committee was access to collateral information. So we have the RIO or Healthy Connections, where we get some information from external organizations, especially the hospital is available there. But for example, having collateral information from OASIS providers or from previous primary care providers or therapy where someone has gone before can be really help our medical staff and also our clinicians make decisions. And I also attend both the treatment team meeting and the intake meeting. So if our medical director is going through and someone's lacking a hospital discharge summary or they requested records and they never came through, then I will immediately follow up with our records department. So it just helps to sort of close the gaps there. And then we also worked with Dr. Lair to create a PCP referral or continuity of care form so that if we discharge somebody and they're going to get their medication with their PCP, so they're stable here and they're sort of ready to graduate or be discharged, that we provide a letter and a form to the physician that with their consent to help the person have their care continued and also to have a backup plan if they need to come back.
Has that started?
Yes.
Okay.
And we worked with CMC pretty recently to coordinate for hospital discharges, a one-on-one nursing handoff. So a verbal conversation about this person is coming from the hospital to outpatient to receive timely discharge summaries that has a lot of valuable information for the medical staff, and then coordination of long-acting injectable medication. So a lot of times people will get their first injection at the hospital and then we'll do the booster and or the next the next injection within 30 days. So it's important that everyone's on the same page about what that medication is, the dosage and the timeframe.
Sorry,
That's
sorry,
okay.
guys, feel free to tell me.
You're interested.
Does this include when they're seen in the emergency room, but not discharged? But not, but not admitted, if they're seen in the emergency department?
When we know about it, so they won't, I think the emergency evaluation, so there's a difference about whether or not they're admitted to the BSU or whether or not they go to the emergency department
Right.
for a broken arm.
Well, also there's a difference, like plenty of people go to the emergency department for suicidal ideation and are discharged without.
Yes, that is true.
Is that included? Do you guys have?
Like,
that?
is the hospital required by OMH to schedule an appointment with us if they don't admit the person?
No, I know the answer. No to that. Does the outpatient clinic through Healthy Connects or some other means track the folks who are just being seen in the emergency department without being admitted?
I will defer to Harmony, but I think that in general, we are the ones helping them get to the hospital and we hope that they're admitted. And so we are also the ones who catch them if they aren't admitted. So I think we're there before and after, generally speaking.
This protocol was fairly recently developed, and it was developed around people being discharged after an inpatient admission because we were not getting that information in as timely way. It seemed like there was a process in place, and then over time it just eroded. So we really wanted to get back to that in-person conversation so you could get all the nuanced, complex information you needed. So this does not specifically address issues around people going to an ED and then maybe discharged and whether or not we get follow-up information. We do get a hospital list. We do know if someone goes to the emergency department, so we can follow up with our own clients that way. And as Jenna was saying, a lot of times if a person's in crisis, we learn about it through our mobile crisis team because we've done a transport order or we help support that person. Or if they're just our clients in general, we've helped support them in getting to the hospital when they need to. So we're aware, but it's not a comprehensive thing. So we're trying to get this down first.
Yeah, and then move on to the ED.
Hopefully start to improve on the ED part as well.
And when someone is stepping down from specialty mental health care to their primary care provider with the referral system, how are the medical records getting up from Tompkins County Mental Health getting to the primary care doctor? Because often the primary care side of the world really struggles to get medical records from the mental health clinic.
I would love to hear more about that because that's my department. So we have up to 30 days to process a request, but we definitely try to take less time than that. As long as there's a release of information and a request that we are obliged to provide that information. The PCP referral form, we work with Dr. Lair about like what relevant information does he want on hand right away about that client. So he wants to know what medications were they on, what allergic reactions or adverse reactions, like what have you tried, what didn't work, what is the person using that does work, and what do I do if this person goes into crisis?
Yeah, boy, I would love those stuff.
And that's a fairly new process and actually came out of a complaint.
Okay.
Yes.
So we worked very hard from a complaint on how to improve this process because we didn't really know exactly what primary care providers wanted as much. And Dr. Lippert now also sits in a group of primary care providers to review on a regular basis, like how do we improve people moving from one level of care to another level of care? Because part of the problem for primary care providers is I'm nervous, right? I'm nervous about this person maybe needing more service than I can provide. So I don't know if I want to treat anybody with, even basic kinds of mental health problems, which means that our system can get overloaded with people with too much complexity. We want to work with the people who have complexity of need, not people that could be treated that way. So this last year, Dr. Lippert started sitting on this committee with them to help sort of be the traffic cops and know, okay, if you have clients that really need more care, we can, through this communication process, we can make sure they come to us. And at the same token, people that really don't need our level of specialization should be going back out to the primary care provider. So I think we're gonna get that process better over time. But this is really nice because this really came out of somebody saying, you guys are really crappy at giving us information. And then we met with him several times and Jenna worked really hard at getting this process put together, but it's still fairly new, so you might not have heard of it yet.
I've literally never seen a note from Hopkins County Mental Health.
So
We've only
I'm
had 2
super
requests so
sad.
far.
So it's a fairly new process,
Yeah.
but that's how it was driven out of that thing. So hopefully you'll start to see that. And if you don't, that's your person.
Okay.
Yeah, just interject quickly, a quick point of order. So we are scheduled to adjourn at 6:30. Is there a specific reason why? Because we usually adjourn at 7.
No.
Okay, I wasn't sure if someone had to go or if we were,
No.
okay. Because I just wanted to be able to finish your report and then we still have.
Is that okay? I know I'm over.
Yeah, I know. I just wanted to make sure we didn't have a reason that we had to adjourn at 6:30 because
Okay.
we usually don't. Okay.
So client engagement is related to caseload management. So we have open access hours that they are Monday, Tuesday, Wednesday, and Thursday. That we developed an easy referral form, which is mostly, I think, to help the client feel more confident coming through the doors, that they have a piece of paper that a provider gave them, like an invitation that says that they're welcome to be here, but they can also walk in without the referral form. And then we use scheduling data to monitor new intakes. So basically to make sure that we're utilizing our time effectively and offering appointments to new clients. We also have an engagement letter process. So as mentioned, that clinicians get a caseload list. So they can see how many days it's been since someone is seen, and there's a different letter for every amount of time not seen. So whether or not the person hasn't been seen in 30, 60, or 90 days, there's a different corresponding letter with a different level of engagement. So ranging from we miss you, please come back and schedule another appointment, to we've sent you 2 letters and this is a pending discharge if we don't hear from you, that we're going to discharge you, which oftentimes will bring people back. So this was a clinician recommendation. So it's in the electronic health record. It's a form letter, but they have an opportunity to write something personalized. And then we send out letters in bulk every week. That the OMH Psyches project, so that OMH has like a quality improvement project for all of the clinics in New York State. And they really liked our letters and used them as an example for other organizations. And then recently, we have a suggestion to include a copy of our attendance agreement in the letter. So if someone has a pending discharge letter, we can say, hey, you signed this thing on this date that says that you want to come to services and that you hope to improve in these ways, and you agreed to that, just to sort of close the loop. So this is data for comparing 21 and 2022, our open access and assessment data. So it's a little bit small, I apologize. Your access on the left-hand side is number of days. So you can see that in December and January of 2021 and 2022, there was a very long period of time for when someone walked through the door and when they were admitted. And that was at the point when we had a press release that we were only accepting critically acute clients, and we were very understaffed. Since then, we have had a lot of efforts to hire new staff and retain staff and to streamline our processes. And so now it's about 17 days, a little less than 17 days, for someone to walk through the doors, get their intake 1, be assigned a primary clinician, get their intake 2, and then go to that intake meeting and be admitted with a treatment team. So that is, I think, one of our more notable achievements in the past year. So some of the things that were done to help that improvement process, which I think Harmony gets a lot of kudos in this one, that we applied to be a HRSA site for loan repayment. So in 2022, we were successfully certified for the National Health Service Corps. And we have 8 staff who are participating. And that also increased some clinicians' hours from 35 to 40. So that provided more clinician time. And there's 7 social workers and 1 nurse practitioner who's participating in that. And then we also hired 11 new service providers I think there were 2 people that we lost. So all in all, we have 9 more direct service staff as compared to 2021, which is a huge proportion. And then we expanded the civil service job description to licensed clinical therapist. So now there are more mental health licensure qualifications that people can apply with. So a licensed master social worker, a licensed clinical social worker, a creative arts therapist, a licensed marriage and family therapist, and a licensed mental health counselor can all now work at our clinic. So this is, I think, interesting data. So you see on the left-hand side, that's the beginning of the COVID-19 pandemic where everything was in person. And then the blue line's in person, the gray line is telehealth. And so you can see that initially almost everyone other than our long-acting injectable clients who had to come in was telehealth. And now people are sort of gravitating back to in-person very slowly. So as compared to 2021, 53% of our clients our services were delivered in person. And then in this past year in 2022, 60% were delivered in person. We have a telehealth consent where we do an assessment with somebody about their appropriateness for telehealth, which indicates that most people do want to be seen in person. That the telehealth or the hybrid approach, I think, really offers people alternatives when they don't have daycare, when there's weather, when they don't have transportation. So I think that was very interesting to me that people would prefer to be in person when they're able to be, generally. As mentioned, some of the incidents were violent, and one of which happened on site. And so we have, I think, been very intentional about creating a safe and welcoming environment while also improving our safety and our preparedness. So this is a long list of many things which have been done or are in process, including a de-escalation training, an emergency evacuation training, new cameras, installation of fobs on the stairwells to improve our lockdown response. We tested and trained staff on a paging system. We got walkie-talkies and we used them. We standardized our messaging during a time of emergency so that we communicate clearly with each other. That we have a supervisor on duty every day. We're updating our policies and procedures, which is a process. There's plans to remodel some of the parts of the front lobby to improve safety for front desk staff. We're evaluating, the county at large is evaluating a standardized alert system. We proposed duress buttons, which haven't happened yet. And we have ongoing consultation with subject matter experts to develop best practices and to inform our policies. And then we have an internal safety committee, which convenes monthly to discuss progress and updates and suggestions. And then these are, this just highlights some of the policy changes which have happened in the past year or are happening now. So for example, our high risk policy. So when clinicians go out on leave for 2 or more weeks, that we now will assign their high risk clients to another clinician and follow up with the client to make sure that they're being seen. Because sometimes people go out and we don't know how long they're going to go out for. And so that was identified as an area where we can improve. That we're updating our LAI policy to include the 5 R's of healthcare. So right patient, right drug, right dose, right route, and right time. As just mentioned, the emergency response policies there's multiple and they are in process. Our telehealth policy, psychiatric intakes are provided in person whenever possible. So our medical director was pretty firm that you can't really evaluate somebody effectively on Zoom. And our naloxone distribution policy. So we are an OOPP and we are able to distribute Narcan kits directly to clients when clinically indicated. Any more questions?
Got a question.
Yeah.
So when a client comes from another county, do you use the data they have for treating them in that county, or do you have to start over?
We only serve people who live, work, or study in Tompkins.
Sorry.
We only serve people who live, work, or study in Tompkins County.
But what if they came from another county and they were in that program and they moved here?
What data do you mean?
So say somebody's a client in Schuyler County.
Yep.
And they're going through treatments, whatever, and they, for whatever reason, come here.
Mhm.
So do you start off with the client with they're working with their Skylar, or do you have to start over?
I'm not sure if I'm answering.
So do you have,
tell me if I'm answering.
they've got, plans they're working with on their client there and what drugs they may be giving to them or whatever.
Yes.
And then they move here and they don't tell you they came from there. Do you have to start over or how does that work?
We would hope that they would tell us their
But they
previous
don't tell you to
providers.
Start over? You have to-
I think we do rely on clients telling us who their PCP is or where they've gotten mental health services before. And then we get a release of information and request records from those other providers. And then we we'll work with them. I think oftentimes clinicians will make a phone call with a release and have a conversation. But we rely on the client both to tell us who that provider is and to give us consent to talk to them and get the records.
Larry, did you have a question?
So I didn't have a question as much as a comment. I'm really impressed by this report as I was with last year's report. So I have a comment to make about the criminal incidents that happened, and that is to say that I thought that the media coverage around that was fairly good. And so I think we're getting better at responding to media and also putting out what we want to put out about what happened. So I appreciate that very much. So I feel much better informed in the last couple of years about about incident review than I have in previous years. So thank you very much.
Thanks. I think it's also important to note that our clinicians are very empathic, even to the person who is the violent offender in those scenarios. And in the moment and retrospectively, I think that they are also our clients and that there is also a desire to care for them and to address their mental health needs and to help them feel safe because it reduces their proclivity to be violent. So I think there's an understanding of that.
Okay, any other questions? Thank you so much.
Yeah, great.
All right, Harmony, framework for orientation for board members.
So this should be hopefully a discussion with you. And I was thinking, since it's a pretty new year, right? February, that it might be helpful to think about an onboarding process for new members. Because when I look around the room, I see some new members. And I know we've been talking about how to get new members. And a part of that might be in like, okay, then once you get a new member,
So
the phases of somebody becoming a member to the board, like the recruitment phase. And I know in the past, there's been discussions about figuring out, well, what kinds of expertise, knowledge, skills do we need? And are we recruiting directly for those kinds of things for board members? And then how do we advertise? So that's sort of the recruitment piece. And then you'll see an application phase. That's sort of the whole thing that people have to do, from filling out the application to getting reviewed by the nominating committee to then having it approved through the legislature. And then hopefully someone notifies and they get a letter, right? And they come to their meeting and they have to go and they have to vow that they're going to follow the rules and all the things they have to do. And then it's like, okay, and then what happens? So I wrote down a couple of ideas, but I really wanted it to be more of a discussion, like maybe what you thought was helpful for you as a new member. Do you even want to do this? Is this something that's interesting to you or important to you? Should people get a welcome packet? If they should get a welcome packet, what should be in there? Are there people they should meet with? So they get a better understanding of the whole process. For me, having been an ex-board member, I can say I kind of learned when someone would say, well, years ago, we used to do it X, Y, and Z, right? That's kind of how you learned instead of having like a structured process. I know last year we had Jed Woolbright, am I saying his name right? Jed Wolkenbright, who is the legal counsel for the Conference of Local Mental Hygiene Directors. And he did this whole presentation. We have that recorded. and we have that PowerPoint. Do we want to give that to new members who didn't attend? Do we want to ask him to come back sometime in this year to do it again for us? Now that we've done the whole merger. So that's all I have. A few ideas and really like open it up for a discussion for you about what you think might make join. And it'll be great to hear from newer members to say, well, this is kind of, was it a good experience? Was it like not so great experience? What would you like to have that we could add to this year?
I'm glad you mentioned his presentation. I thought it was fantastic and very helpful and informative. So I think for someone coming in, that could be a helpful way to orient them to what our responsibility is. He was really clear. Thought it was well done.
I think one of the things that would need to be defined is whose role is it to do the orienting? When I was brought on, whenever that was it Sharon? Did orientation sessions where she reviewed the sections of the mental hygiene law that applied. So I actually wasn't aware that new members now weren't getting that same orientation in mental hygiene law. So is that, something that you would do, Harmony? Is that something you'd like to, the chair to take on, or where does that responsibility lie? And I think they're all good ideas. It's just a matter of who's going to execute them.
And kind of, what do you guys want? What would you think would work? Is it helpful for people to meet the chair, the DCS together and meet with the commissioner? Or is it like, I don't know, what more ideas of how you want to do it, what you want to have shared? Did you feel that the information made you understand your role better when you came on?
Yeah, it was interesting because I had been on subcommittees for many years and never thought about why the subcommittees existed. They just existed. They were just meetings I went to because, and then, learning more about where the, what the statute is and why we have this board and how the committees fit in, sort of like all the puzzle pieces finally fit together after many years. So I thought it was interesting.
Does Jed's presentation, I think that covers some of that. So that might be I would like to meet personally with the new folks, right? I mean, I think that was something in the past that we had done pre-COVID, right? Whenever a new board member came on, we'd invite them in, and if they wanted a tour of the building, we'd show them around, and we just talk about what the board does and kind of generally answer those questions. So for me, it's just good to know, and I imagine for Harmony, the new board members and kind of what their interests are and what brings them to the board and what questions they have, as they start on this endeavor. So, I mean, from that perspective, I would appreciate having an opportunity to meet with folks. And
it would help me to have more information as to how I can be more helpful, what kind of role could I play and what sorts of, I so far feel slightly up in the air. I mean, I've learned something each meeting I've come to, and the stuff that's been said, I've learned a lot, but I could use a little more.
Like a more formal, grounding into like what Elise is saying, right? How many years are you on the board before you find out why the board exists, right? It'd be nice to kind of that. You're one. Yeah.
And Mary, you had shared a nice idea at one point where you thought that it would be helpful maybe if more veteran members would come a little bit early on certain meeting days so that newer members could come and just have an informal conversation about any questions that people have and they don't want to, ask in the middle of a meeting maybe, or.
Yeah, that might be one way. Other possibilities are some kind of buddy system for a new person who you knew that someone was going to check in with you each month. What did you think of during that meeting? What questions came up for you? Things you may think about after the meeting that you want some clarification on. So it seems like there's different categories of getting information, but also some kind of ongoing support so that you're feeling as comfortable and effective on the board as possible.
I think it's especially important. I think an advisory board is a very specific kind of thing that people sometimes struggle to remain engaged with because it sometimes it feels like it's not very actionable, right? So you say, I feel up in the air. I'm not really sure. What is my role here? What am I supposed to do? And often our product is actually our perspective, but that can be a little bit hard to quantify. Or it could be something as concrete as maybe we're going to look at some proposals for how some of this opioid money gets spent, right? So for long stretches of time, it may not feel very concrete. And then people start kind of scratching their heads like, why am I here? What is my role? And I think the more we explain that or keep a dialogue going around that, the more likely people are to stay engaged and connected.
I would add, I definitely agree, or I think the buddy system is a great tool. I definitely lean on Karen a lot. I email her for certain things. I think just things that are coming to mind, meeting with Frank or someone prior to the meeting, because if you're coming and, you're just coming in time, not knowing expectations, or even an email, like saying this is kind of like the procedure of the meeting, what happens, the agenda, if you're allowed to speak or not speak. I know for a few times I was like, do I comment? Do I ask questions? Is it appropriate? Is it not? So like knowing kind of like those guidelines so that I can feel comfortable of, can I ask questions, or is this more of a listen and, you vote when we ask you to vote? I think that that's something that would definitely be helpful. And, I think the buddy system, kind of like a sponsor, if you were in some sort of recovery, just so that when there's new information or things that, are historic, being able to lean on like Larry and be able to ask him questions as far as like, hey, like, why is this the way it is? Like the members that've been here for a long time. I think it's, I think that it's great having those that have been here for a long time. And then, if they're open to it, because, everyone works and has another, something else, but it would be nice to have outside of the board meeting, a different meeting or gathering where we're learning that, or, if you have a pre-recorded or a handbook, I'm not sure what's available for us to do on our own time, and be able to like just review and understand like the history of the board.
It would also be great, one, if like current members could get some of this onboarding also, in terms of like, boy, this stuff sounds great. I would love any and all guidance as to these kinds of things. So I would love to opt into going through an orientation now. Also, is there a space or like a shared virtual space where these materials could live, that we could refer back to them outside of email, so that it's not this like one and done, but if you want to look back, or like a place where all of the minutes live?
Yeah, there isn't right now because we haven't built that out on the website, but it is on the to-do list.
Okay.
The Board of Health is that way. So if you ever go to their webpage, you can see the history of their packets and minutes. And we very much want to do that for this board as well. We just haven't gotten there yet, but we can escalate that with our folks and see if we can't get that up and running, because we wanted that for a while. I think working backwards on what you said, we would invite, I think what I'm hearing is we should share out the video from Jed, let folks have a chance to review that. And then why don't we have an open invitation for anyone that's currently on the board that wants to come and, come in, you can sit with us around the table, and Harmony and I can, kind of cover some of the details or answer questions. And hopefully Elise or someone else representing the board can be there as well. Because one of the challenges is for us is that you're our board, right? And so I always feel a little bit of discomfort telling you how you should act or be as a part of this board, right? So I certainly wouldn't tell the legislature as my, the people that hire me, how they should, run their meetings. So we definitely want to be supportive and we'll give whatever, thoughts that we have, but it'd be really good to have a board member be a part of that. So, you can hear from your colleagues about, what that should look like and such. So, I think that's something we can put together relatively quickly if we get the video sent out to folks, and then we can send out a couple of dates and see if that works. It'd be better if it was during the daytime for us. So that might be a bit more challenging for some of you, but we can certainly try to find some times and make that happen, coordinate with you, Elise.
Sure.
Might be available.
I don't know people's schedules, but sometimes it's easier toward the end of the workday if you.
Yes.
Yeah.
And your point about like, do I talk into me? I kind of remember that when you like asking, is it okay if I say it? And we're like, yeah. But that just, even if it's something short that we maybe give people right off the bat when they become a new member, here's what you can expect. And then maybe in the first 90 days, we can do something, give somebody a video to watch or schedule the meeting within the first 90 days. So they have the time to absorb it all. But at least that initial thing, or maybe that's what you're talking about, Mary, with pairing with somebody who can talk about, here's what to expect. Yeah.
Because we could certainly plan something. So your terms all expire at the end of the year, calendar year, different years, of course, but they expire. So in theory, new people would all be starting at the beginning of the year. So that could be when we plan kind of the big, introductory to those new folks, and then figure out a shorter, more compact for the vacancies that occur, over the course of the year, which honestly had been happening a lot. So that's part of why we got a little bit off track, is because there was new folks, seemingly, every month there for a while. But yeah, I think we can certainly work on putting something together.
And at least what you said, I think would put, even if I was like, oh, I wish we could just videotape what you just said or record what you just said, for a lot of new members to hear, like, don't expect that you're going to come in and do all these massive concrete changes to things. You still bring a lot of value because you bring perspective, you bring your wisdom and all of what you think we should be really focusing on. And when people hear that, hopefully that gives them a little, I'm okay. I'm not like messing this board up.
Yeah, I think a lot of times people feel like, am I supposed to be doing something that I'm not doing? Because it feels like I'm not doing anything, and then people start to wonder. And then sometimes we really do have some concrete things that can be done. So it just, it's sort of cyclical. So.
And I think it does take time too. And
Yeah.
you have to give yourself that.
Yeah.
But if there is somewhere like a statement of the board's, purpose and functions and just.
And the bylaws are pretty detailed about that too. And that's what
we don't, I didn't ever get sent a copy of the
that's a
bylaws.
problem.
It really matters, right? It's not that I couldn't have asked.
Yes.
Shouldn't have to, right?
Get that when you start.
But just,
Yeah.
And that happened before, because I remember I received, I think maybe it was from me, you, Jan, I can't remember, but I remember receiving bylaws and something else too.
But those should also be on our website too.
Yeah.
Right. So that's part of, I think we're going to need to escalate that, because I think that would help with this process too. Again, the Board of Health piece has that. The bylaws are there, the members are there with their contact information, as well as minutes and agendas and things. Not that this board was ever seen as less, but that board has a lot of activity. They are voting every meeting on enforcement and issuing fines. And so it's a much more active from that perspective, and it requires more notification and such. So it kind of forced our hand to move that forward more quickly. So we can talk with our folks. I know it's in the hopper for things, but with whole health rollout, and we've changed the whole website in order to make it whole health. We haven't gotten there yet, but we can talk with our communications folks and try to make that happen.
But
It's not Already?
It is, the
Oh.
board meeting minutes. Yeah, and the description is on the top.
Most of-
Yeah,
don't go back that many
Right.
years. Just started it like 2 years ago, right? A year
Yeah.
ago. We have one full.
no, but the bylaws and the description of the advisory boards are on the top.
I thought I was
County-
different.
I'm sorry, I showed you what I.
Would you mind sending the link to that page to everyone?
Yes. I'll
Right
do
to
it.
it.
Yeah.
Show you.
Larry, did you have something you wanted to say?
Actually, this,
Bylaws are not on ours, but it's on the county legislation where some people find that the positions are available and a description of all of the advisory boards. So it's on the county website for the legislature.
Okay.
Oh, look at this. You guys are good. Okay, so it's.
We could just add a few more things to it and get it like, and once the bylaws are finalized, we maybe waiting on that too.
We'll share the link out.
so
Sorry, Larry, go ahead.
I would like, I assume that, we're developing the Tompkins County Whole Health, presence on the web. I would like at some point to have a meeting where we, as members of the board, give feedback about, what's currently out there, because I noticed a few things that, make me uncomfortable about the presence of the mental health department on the web as opposed to the health department, even on the government, even on the website we just saw. It's easier to find information about what the health department does on that website, what the mental health department does. So I'd like to have a meeting where we talk about what the presence of the whole health should be going forward.
We're always open to that feedback, Larry. So,
Yeah.
send it along. We can certainly talk.
I would like to have a structured time at a meeting where we do that.
I wonder if that might not be best as a subgroup because it probably requires people digging into the website quite a bit and then making recommendations. So,
We can figure it out. But
yeah, let's talk about it.
But I particularly want to make sure that the mental health aspects of Tompkins County Whole Health are well represented on whatever websites we have. And I'm a little concerned about how we show up on even the Tompkins County Gov website.
And Larry, other people have sent me feedback. And then I'm able to send it right to the people who design it. So don't feel you have to wait until we get this subgroup together as well. If there's like particular things, I've had people send me feedback and it's always been well received. I review what they say. I send it along to the people who've like designed the website part of it and say, here's some recommendations I'm hearing from people for them to look at it. Cause you need multiple perspectives to make a good website.
Yep.
Good
Okay.
idea.
Any other thoughts about orientation? All right, thanks for bringing that up, Harmony. If there's nothing else, then we'll entertain a motion to adjourn. So. Right, Travis moved and seconded. All right.
Bye, Larry.
Just made this one.
Bye.
Love it.